too comfortable with just because we see it all the time. And just because we see it all the time doesn't mean it doesn't warrant our absolute attention every time we see an order. Liposomal formulations sometimes pop up, so like doxorubicin and amphotericin are some that are probably more common. Their concentrations tend to vary a lot. 1 milligram of a liposomal formulation of amphotericin does not equal a 1 milligram formulation of the non-liposomal. MAOIs tend to make the list. They have complex drug interactions, but as a result, the attention that MAOIs have received, you really don't see these drugs prescribed anymore. There's a few patients that may be on one that are kind of grandfathered in, so to speak. Digoxin. Digoxin is a very risky drug. It has a narrow therapeutic index, and so tends to make the list in hospitals especially. Of course, we do drug level monitoring just like we do with several other narrow therapeutic index drugs. Digoxin really is one of those drugs that there's a lot of interpatient variability. This is by no means a comprehensive and complete list. For testing purposes, this is definitely the list I would look at and consider and definitely listen to the rationale behind their additions to the high alert lists. For your reference, and I would definitely save this for whenever you go on your hospital rotations and also your community rotations, I've given you hyperlinks on this slide to both the acute care and the community high alert drug lists from ISMP, and we'll talk about Soundalike drugs. So we're going to talk about Soundalikes and Lookalikes. Soundalike drugs tend to be sometimes look-alike as well, just because the names tend to be kind of similar. So for instance, whenever you look on the left here, you'll see like phenobarbital and pentobarbital, which I put it at the top because that was one of the first medication errors that I did root cause analysis for, and it is a massive tenfold difference in dosing, and the result can be catastrophic. Also, many chemotherapy drugs, the next three are listed there. Of course, metoprolol and methocarbamol. All of these look really similar at first blush. It's also very easy if you imagine not being a pharmacist and you don't see one of these drugs as often, you may very easily confuse it for another. So what's been required by the FDA for certain drugs that are considered sound-alike is tall man lettering, and there's a great example here under the strategies to employ nifedipine and nicardipine, and you tend to see this tall man lettering. You'll see it in not just on the drug labeling, but it should also be in databases like on automated dispensing cabinets, in carousels, IV workflows, in electronic health records. It should be everywhere. The other thing to do is to separate these drugs to prevent errors. So whenever you have storage devices such as automated dispensing cabinets up on nursing units, it's always a good idea to keep drugs either in separate drawers or in pockets that are completely closed from one another so that the drugs can't accidentally. So this is kind of what I was talking about, this inappropriate abbreviations, is what I was talking about when I said some of it has kind of lost its vogue, so to speak. So the Joint Commission put out this do not use abbreviation list, and this is mostly from the days of handwritten medication orders, and was the consequence of bad, questionable, or interpretive, as we used to put it, handwriting. So a lot of times this is the reason we don't use the QD abbreviation anymore. This is the reason we don't use U instead of units. Probably the one mistake that I've seen universally that still happens, especially in progress notes and in handwritten anything, is the use of leading zeros and trailing zeros. So we always want to use leading zeros, so like 0.2 instead of just 0.2. But the one that I see done more inaccurately though is trailing zeros, so like 5.0, and as a result it's very easy to misread that as 50, and there's been documented many sentinel events and catastrophic events where trailing zeros have resulted in tenfold overdoses. So we talked about lookalikes, so here is soundalikes, and historically I've referred these in a can't claim credit for this phrase, but another pharmacy director pointed out to me is referring to Soundalikes and Lookalikes together as a salad list of drugs. So Soundalike, Lookalike, drugs. And kind of creating that single one-stop shop, because a lot of lookalikes are soundalikes, and I've provided a good example of that in the top right-hand corner here. We have metronidazole and metformin, but at first blush, not only do the bottles look the same, but the drug names kind of look the same too. It'd be pretty easy to mix it up. Lookalike has become more and more a concern as the number of generic manufacturers has decreased, but the number of products that they put out has increased. And so all these drugs put out by Baxter, all these drugs put out by Hospira that produce these massive and variable quantities of generic drugs, they all look the same. And so you have to be really, really careful with this. What's really interesting is your inventories tend to fluctuate. So you may not have the same manufacturer of neostigmine today that you do tomorrow. And so tomorrow's dose may look just like your Milrinone, or it may look totally different. And so a lookalike list you really kind of have to keep tabs on based on what product you are purchasing at any given time. Lookalike is also a consideration when you have multiple doses like we do with warfarin and heparin. Heparin, you could easily look up heparin errors in your Google search, and you'll find so many tragic and catastrophic errors that have occurred because of using a 10,000 unit per mil instead of a 10 unit per mil. Because we do use heparin in neonates, especially for line patency, we tend to see unfortunately a larger number of errors regarding heparin in that population, and it's almost always catastrophic or near catastrophic. The other thing to consider with lookalikes is in hospitals, one of the cost-saving mechanisms that we have in place is to repackage from bulk bottles, because in hospitals we're required to unit dose. And so whenever we repackage bulk bottles, all of our packaging looks exactly the same. And so even though the drugs normally wouldn't be lookalike, they become lookalike because of the fact that the packaging is exactly the same. And if the tablet or capsule looks even remotely similar, the likelihood of error is huge. The other lookalike issue that we run into is large volume IV solutions. So if you grab one particular manufacturer, so let's say we're using Baxter for example, if we take a dextrose 5% solution and put it next to a dextrose 5% solution with normal saline, they're going to look very, very similar. And someone in a hurry could easily mix those up. So it's important to make sure that we find ways to flag solutions that look similar. One of the ones that stands out is the fact of solutions with potassium. And so some manufacturers have been helpful enough to put solutions that are in potassium in a red print instead of a black print, so they kind of stand out. The problem with this is usually sterile water for injection is typically also in a red print to make it stand out, and so the likelihood of mistaking those two solutions is kind of high. Hazardous drugs, whenever we talk about hazardous drugs, if you would have heard a hazardous drug lecture 5 years ago, it almost always, if not always, meant hazardous to personnel. And so we're talking about chemotherapy in particular, or antineoplastics. And then of course we have other hazardous drugs too that can pose a reproductive hazard to patients, to preparers, to administrators, etc. And then there's also drugs that can cause some organ toxicity as well. The National Institute of Occupational Safety and Health has created a list that used to be a guideline. According to USP 797, USP 800, that guideline is now a requirement. So every drug that is listed on the NIOSH drug list, hazardous drug list, is considered a hazardous drug, period, and must be, if it is manipulated or prepared, it has to be done in a appropriate environment. Now, whenever we consider hazardous drugs, now we have to consider hazardous to the environment drugs. So recently there was an inspection at a hospital here in the Metroplex by the EPA. It's the only time I've ever heard of an EPA entering a hospital pharmacy. And they were there to specifically check on compliance with the Resource Conservation and Recovery Act, or you'll hear it sometimes referred to briefly as RCRA, as far as disposing of drugs. There are different categories of drugs. Specifically, there's the P list, there's the U list, and then there's property-based toxicity. And when we talk about the toxicity, we're talking about toxicity to the environment. So P-listed drugs are considered acutely toxic, and the ones that really stand out that you see in most pharmacies is going to be warfarin and then also nicotine. Although epinephrine appears on the P list, its sulfate component, which is almost the entirety of its availability is as a sulfate component, is not listed as hazardous to the environment. These drugs actually have a special disposal method. You even have to dispose of the wrappers that they come in. And so this has become very problematic in that whenever we have warfarin being administered in a nursing unit, we have to make sure that all of our nursing staff are educated to discard the wrapper in an appropriate manner. To the right side of this slide, you'll see a yellow bin, you'll see a black bin. The yellow bin really is designed for chemotherapy waste, so that's going to be your hazardous to personnel drugs. Whereas the black bin, or our RCRA bin, is where we put everything that falls in this hazardous to the environment category. Where things really get confusing is where we have drugs like arsenic trioxide, which falls into both categories, and typically we err to put it in the yellow bucket instead. What's really made things complex is property-based hazards. So this actually includes aerosols, so we're talking about our inhalers. It also includes products that contain M-cresol. M-cresol, if you're not aware, is a component in our foggy insulins. So in our NPH insulins, we tend to have a considerable quantity of M-cresol, and so it has to be disposed of properly as well. Everything except the P list, we don't have to save. We only have to discard actual drug or partial drug. We don't have to discard the containers in the black bin for all of those as well. That's only going to be, again, nicotine patch containers and the remainder of the patch, and then also the wrappers from warfarin, and containers for warfarin have to be disposed of in the black bin as well. Unfortunately, the EPA really hasn't provided a whole lot of guidance for these drugs taken at home. So if we dispense a prescription for warfarin, there's really nothing to address the bottles being discarded, the containers that are actually holding the warfarin. So I'm interested to see if they expand on that, or basically, as it seems they are currently kind of just. So all of these types of problematic categories of drugs, and then also the strategies we use to enhance their safety, fall at different points on the med use process or within the system. And so really inappropriate abbreviations are going to happen in that prescribing and transcribing. High alert drugs really are going to span that entire spectrum, including monitoring. Mostly because many of those high alert drugs, such as anticoagulants and antithrombolytics, tend to require pretty intense monitoring. And if we fail to monitor, then we've failed our patient and increased the likelihood of an error. Soundalike really spans from prescribing all the way to administering, whereas lookalike drugs tend to be more in that dispensing and administering category. Hazardous drugs, of course, are going to be really, there's no massive concerns around prescribing and transcribing, except for maybe a dosing error. But really we're more concerned about exposure to people and the environment throughout the dispensing. We have to make sure that those that are administering these drugs are kept safe and understand proper protocols to keep themselves and others safe. And then, of course, we really need to monitor our patients that are on these drugs for adverse events and the like. And if we fail to do that, then again, and on that very somber note, I want to transition here and talk a little bit about some of this is going to seem a little no-brainer, but talk about the physical environments where the medication use process and medication use system occurs. All the slides that I'm about to disclose to you are actually specifically taken from USP Chapter 1066. And if you recall from sterile compounding and other courses, whenever we talk about USP chapters, the FDA reserves the right to enforce any USP chapter under 1,000. So 1066 is really a guideline, a suggestion. It's not a requirement like 797 and 800 and similar such.